And so, as the title indicates, I'll be giving a national overview of barriers and challenges at the intersection of transportation, gender, safety, and health. And then my fellow panelists will be going into more health-specific research. I would like to begin with this image. It's of the Montgomery bus boycott to desegregate buses. And next Monday, we will be celebrating Dr. Martin Luther King Jr.'s birthday, who became the public-facing leader of the boycott, which actually launched his leadership of the civil rights movement. However, it was the organizing efforts of Black women, particularly the planning of the Women's Political Council and the participation of domestic workers who had relied heavily on the bus, that made the boycott successful. And so in this image, as you see, the young ladies are smiling. And as one elder Black woman has said, quote, "Since I've been walking, my feet are tired, but my soul's rested." Transportation is a long-standing civil rights issue. It's been used as a means of controlling the movement of people. And so today we're still in the struggle for transportation equity, which is fundamentally about mobility and mobility justice, which, as Charles Brown of Equitable Cities says, is really about freedom. Dr. Destiny de Guzman, formerly Thomas, as you may more commonly know her as, of the Thrivance Group states, quote, "Mobility justice is about freedom of movement, freedom to navigate space and place in the absence of racism." So again, this is about freedom, people moving freely and easily in space and place, and being able to do so safely. And that requires us acknowledging and addressing racism, white supremacy, patriarchy, ableism, and transphobia in transportation planning that shapes our transportation system. And so transportation planning decisions and infrastructure development have systematically created inequitable transportation systems that restrict mobility along race, class, and gender lines. Transportation investments control access to opportunity and services. For instance, there's disinvestment in public transit to prioritize car-centric planning practices, which is facilitated by investment prioritization of roadways, particularly highways. And highway construction expansion has inequitably impacted poor communities of color. Historical and contemporary highway construction expansion, which is what my current research focuses on, results in the demolition, division, and displacement of neighborhoods, as well as the destruction of local economies. And so here's an image of Atlanta, and really showing the impact of highway construction. And this has and continues to happen all over the nation. I want to emphasize that this is not just a historical practice, but continues today, particularly in LA. And so infrastructure serves as tools of segregation and economic discrimination. Car-centric planning practices privilege white suburban commuters and reinforce racial residential segregation. Racial borders and inaccessibility are literally concretized into our built environment with freeway construction. So in today's presentation, I'll draw from this brief titled Gender, Climate, and Transport in the United States to discuss how infrastructure and transportation systems differently impact all genders along intersecting identities such as race and class. And at its core, this brief really supports the need for an intersectional feminist lens to transition the transportation system to an equitable and sustainable system. Planning practices, which have historically centered the concerns of white, middle-class, cisgender men, along with issues of affordability and safety, contribute to inequitable transportation systems that hinder mobility. And so the brief offers policy recommendations, which I'll go over shortly, for systematically integrating considerations of gender as well as the care economy. So one challenge to accessing healthcare and other critical destinations is planning practices. So single-use zoning, for instance, which is rooted in traditional binary gender roles and gender division of labor, separates work, residential, and care areas. This practice increases the distance between care and non-care work, and this limits things like walkability to employment and services, such as healthcare, grocery stores, and education, as well as insufficient pedestrian infrastructure. But distance, therefore, increases automobile dependency. However, women have less access to automobiles. 11% of women-based households don't even have access to a car, compared to 7% of male-headed households. And this varies by race and ethnicity. For instance, 21% of Black women-headed households don't have access, which is the highest percentage. And so due to dominant planning practices, living in a zero-vehicle household, or even living in an auto-deficient household, which is defined as those that have fewer vehicles than drivers, It makes it difficult to reach destinations. Then we look at public transit, where most riders, 55%, are women. Yet transit systems don't account for the mobility needs of all genders. For instance, public transit schedules prioritize the traditional male 9-to-5 commute, which creates barriers for part-time, service, informal, and care work. And there's less reliable and less frequent service during off-peak hours. Further, public transit fare policies are around direct commutes, but women have to pay multiple times as they make multiple stops for care work, which increases their trip costs. And on top of that, vehicles and facilities often aren't designed for care work, including not allowing open strollers or stops without benches. Another barrier to access is affordability. Transportation is the second largest household expenditure after housing. It's a financial burden on low-income households. With women experiencing high poverty rates, 56% of people living in poverty are women, and poverty rates vary by race and ethnicity. Indigenous women have the highest poverty rate at 25%, followed by Black women and Latinas. And two contributors to the gender disparity in poverty rates are, one, the gender wage gap, and two, the lack of reliable and affordable care. And so women work part-time at a higher rate than men, and 1/3 of women part-time workers actually work part-time because of childcare reasons or other family obligations. Then additionally, transgender people have high poverty rates at 29%. The unemployment rate is high, particularly among Indigenous, Latinx, and Black Indigenous people, with access to jobs hindered by mistreatment, discrimination, and harassment. And so to further illustrate a point I just made, around the time that this brief was published, this news story by CNN was getting a lot of attention, where U.S. employers cut 140,000 jobs, according to the latest job report. Women accounted for all of the losses, losing 156,000 jobs, while men gained 16,000. And according to the National Women's Law Center, 154 of those 156,000 jobs were lost by Black women. And a major factor is that is the lack of childcare and other caregiving responsibilities. A study found that during that pandemic, daycare centers were more likely to close in Black and Latinx neighborhoods. Further, Black women and Latinas disproportionately work in sectors hit hardest by the pandemic, including paid care work, such as healthcare aides. And so I started this presentation by recognizing the role of domestic workers in the Montgomery bus boycott. And I think it's important that we center them and other care workers when we're addressing this intersection of transportation, gender, access, and health. And so now to really get back to this idea of freedom of movement, we must look at safety. And one key issue is gender-based harassment and violence, which is pervasive on public transit. Nationally, 25% of women report experiencing sexual harassment. 32% of transgender riders who thought employees thought or knew they were transgender report experiences of unequal treatment or harassment, and 39% of non-binary people have experienced unequal treatment or harassment. And importantly, harassment and violence are largely underreported. The brief also includes some city-specific data, including from an LA Metro survey, which may be discussed on the third panel, so I hope you stay. And this issue affects mobility, whereby fear of harassment and violence impedes freedom of movement. Women will modify their travel behavior to avoid certain settings, like not walking alone or not riding public transit, and this can result in something known as the pink tax on women, where women with a financial ability will use ride-hailing services due to fear and safety concerns. I for certain know that I've taken Lyft at night despite a short distance to a bus or metro stop because of safety concerns. And these concerns are only exacerbated by transit stops with poor lighting or long wait times. And so all of these challenges that I've discussed really reflect that women's voices are underrepresented in the planning process and decision-making, both in leadership, as shown here, and operation and construction. And so transportation agencies intentionally centering equity should be reflected in the agency's diversity, which requires measures to hire, retain, promote, and equally pay women and folks from other marginalized groups. So what are the interventions that can improve safe and inclusive transportation access to destinations? So the bipartisan infrastructure law, which was passed shortly after the brief was released, does significantly increase public transit funding. However, it does not fund public transit equally to roads and bridges. And transit parity has gender, racial, and economic implications. There's also a dire need for increased funding for operations as we see transit agencies struggling all over the country. Also, while the Justice 40 initiative aims to deliver 40% of overall benefits of federal investments in climate and clean energy to disadvantaged communities, environmental and climate justice advocates call for 40% of investments to go to frontline communities. Next, transportation and care infrastructure investments should be linked to undo that single-use zoning and enable travel between non-care and care work to be able to reach destinations. However, that actually requires an investment in care infrastructure at all, which was stripped out of the Inflation Reduction Act. Now, the next recommendations focus on how public transit investment can improve design and services. So to address previously mentioned challenges and barriers to ridership, transit agencies should invest in things like vehicles with designated stroller areas, benches, working elevators, it's nice when they actually work, sufficient lighting and real-time information at waiting areas, as well as increased unarmed civilian transit staff for safety, and I'll go into an example shortly. With regard to service, transit agencies should focus on more frequent and reliable service all day, prioritizing off-peak hours. And a Wired article titled Public Transit Systems Refocus on Their Core Riders describes how, due to remote work, several agencies are shifting away from commuter routes and targeting low-income riders and riders of color with more weekend and more frequent off-peak service. Now, in my opinion, one infrastructure and transportation investment that is intersectionally just, that incorporates gender considerations and care work, and that creates an equitable and sustainable transportation system is an investment in accessible, frequent, reliable, safe, and free public transit. So often folks aspire to accessible, frequent, and reliable, but freedom of movement requires safe and sufficient investment to enable free. Free transit increases access for low-income riders and simultaneously addresses the aforementioned fare policy challenges, including increased costs due to trip chaining and multi-stop trips. It also eliminates inequitable fare enforcement, which empowers freedom of movement. Now, in terms of safety, community action has actually led some transit agencies to address gender-based harassment and violence. For example, the Not One More Girl is a BIPOC youth-led initiative to end gender-based violence on BART in the Bay Area in response to a report in town hall that was led by Alliance for Girls. During my interview with Halima Barucha of Alliance for Girls, she stated, quote, "Looking at the aspect of economic access and mobility, education and healthcare, all those pieces basically, access to all the resources that allow you to thrive. If girls don't have access to mobility, they can't go to school. There are data points that we have that show that students had missed school because they didn't feel safe taking public transportation, that they weren't able to keep certain jobs because of getting on public transportation at a later time that they weren't comfortable doing or didn't feel safe doing. It meant missing medical appointments and missing opportunities that enhance their quality of life, even access to community, access to fun. And so it's just really an issue that touches so many areas. And also this is an issue of racial justice because we know this issue is disproportionately impacting Black youth and youth of color, especially when people's first response to this issue is, oh, let's have a police officer on every BART car on every train. Not One More Girl reimagines safety for BIPOC youth and takes an intersectional approach to safe and just passageways. And I read that quote because it really captures all of the many points that I made earlier throughout my presentation. And importantly, as in this example, strategies to systematically integrate considerations of gender must be locally adapted through decision-making processes that involve all genders. And I titled this slide Co-Powerment because it's important not to frame as a public engagement or community empowerment or the empowerment of community members into decision-making, but co-powerment, which really emphasizes collaboration and values community expertise. Thank you.
Heo putis kasihu putis Okello putis lacht Louis Quest, Margo Hill. Good afternoon, everyone. My name is Margo Hill. I'm a Spokane tribal citizen, and I grew up on the Spokane Indian Reservation. I served as attorney for our tribe for a decade, and then I also have a master's in urban and regional planning. So I'm an associate professor at Eastern Washington University, and a co-PI for CERTCOM, Small Urban Rural Tribal Center on Mobility, and Northwest TTAP. We provide technical assistance to tribes. So I'm going to talk to you about indigenous mobility, access to healthcare, talk a little bit about what we learned from COVID, and talk to you a little bit about the Dobbs decision and access to health care. So often indigenous people are kind of a forgotten minority. If you look at reports out in the news, we're the other. But for COVID, we've seen that we experienced the epidemic at greater rates, higher hospitalization, higher mortality than other ethnic groups. And culturally, this had a huge impact. We only have a handful of speakers of our indigenous Salish language. I grew up around speakers and have conversational Salish abilities, but every loss was somebody that held cultural knowledge, either a songkeeper or a storyteller, or in fact our language, and we are critically endangered and threatened in our language capabilities. So there are 5.6 million self-identified indigenous people in the United States, 574 recognized tribes, 326 reservations, and the data is just not clear. It's hard to track who indigenous people are. I do a lot of work on human trafficking and MMIW, missing and murdered indigenous women, which there are a number of publications, and we cannot track who the Native American population are when they are in urban areas. There's antiquated systems for tracking, but we have a real challenge with data. When we look at the treatment of indigenous people by the United States, it's really a shameful record of genocide and other mistreatments that I'll just briefly talk about. And I apologize for moving so fast. I do have a couple of publications that are listed in the slides that will be available for you to look at. The United States government, up until the 50s and 60s, had a policy of termination. Once they took the land from the Native Americans and signed treaties, and to understand, just to give you a little bit of perspective, if you look at the Yakima Nation in Washington State, they ceded 10 million acres to the United States and reserved, that's reservation, 1.2 million acres in exchange for the treaty promises of health care and education. Nevertheless, health care is not funded and education is not funded. We all still had huge debts from Gonzaga School of Law. So just understanding the history of the treatment of indigenous people is important. The misconduct, indigenous women were often sterilized, and they did not know it was non-consensual sterilization. So just some of the things that I'm going to talk about are concepts from social determinants of health, things that all of us as Americans typically enjoy. I just got back from Alaska, the National Tribal Transportation Conference, and we heard from villages. And one of my friends, Dolly, who's Alaska Native, her mom said, when you look out the window at the village house, you can see the river, and you can see the water coming up to the front porch. With climate change, indigenous people get hit first, and they get hit the worst. For Alaska Natives, the permafrost is melting, and that's what they built their homes on, and so their houses are being destabilized. And it's affecting all parts of being able to go to the grocery store. We talk about transportation and mobility because of climate change and the water increasing from the ice melting. That's a huge problem. While I was there, a Dene, a Navajo lady, got up and said that we have little access to water in their homes. 1 in 3 Navajo households are lacking water. She said even the recently drilled domestic water wells that we've drilled now are not providing water to our communities. Housing is still a big issue. I myself grew up in a trailer house. Because of our land tenure that I'll briefly talk about, banks don't come out to the reservation. We don't have banks on the reservation. We don't have construction companies racing out to build houses. There's a 3-year waiting list on any of our housing, our HUD lists. So we have a lot of distress. There's environmental racism. There's many toxic sites of resource extraction in our tribal communities, and this has significant impacts to water, to flora, to fauna. And so this is a real problem for us. When we talk about indigenous communities, this is my reservation. We had a uranium-contaminated Superfund site as long as I was growing up. The mining company pulled out and left this big uranium pit. It filled up with natural water. It's now a Superfund site. And this toxic waste causes increase in cancer rates and a whole host of health problems that we have to deal with. So this is our complicated land tenure. On an Indian reservation, this is the Umatilla Indian Reservation in Oregon. You can see the larger outside and dotted line. That was the original reservation that was reserved in the treaty promises. Well, take away the lower 1/3 because then European settlers moved in, so that the government wanted all that back. And so just the upper left that the Umatilla tribe now has. Our land tenure is trust property, fee property, non-Indian fee. So there's non-Indians that rushed in and moved onto the reservation during the Homesteaders Act. And so we have these different citizens and different land tenure, which causes complication even for criminal jurisdiction. As an attorney, I can tell you it's very hard to protect indigenous women when we have no criminal jurisdiction over non-Indians. So if we married a non-Indian or they moved onto the reservation, we cannot convict them of violent crimes. We have to depend upon our federal partners for domestic violence, for any kinds of criminal acts. So it's a real challenge. The violence against indigenous women is an epidemic, and many of you will have heard or read the magazine article cover that I authored in TRB, Murdered Missing Indigenous Women. So the Indian Health Service is poorly underfunded. If you looked at the expenditures, health programs for Native Americans is stark disparity, 3,000 per capita compared to that of Medicaid, which is 8,000. And again, I apologize for moving. This is the end of this first part of the presentation, and then I'm going to pivot. But there's a perfect storm of poverty. As Regan mentioned, indigenous women live in the highest amounts of poverty, due to mistreatment, to our rural reservations. We didn't ask for our beautiful land to be taken away. Where the city of Spokane is, there's a beautiful waterfalls. We call it Skahet, which is place of fast-moving water. They relocated us 48 miles out to the rural reservation. Dr. Michael Marchand said nobody would choose to live in Nispelem, Washington. And so when you have these rural issues, you have transportation and mobility issues. How to get to health specialists, our clinic doesn't have enough money to have the specialists on site, so we depend upon referrals. And that's called contract health care. And you're only eligible for that if you're an enrolled tribal member living on the reservation. I have had to move off the reservation to get my children education, and so I'm not eligible for any of that contract health. So I just want to pivot and share a little bit more about an article. As an attorney, I very much care about gender issues, and so we authored an article, Assault Upon Women, the Reproductive Rights in the Shadow of the U.S. Supreme Court ruling, the Dobbs decision. And so, of course, this case returned the legality of abortion to the states. So each state will make their own decision, and many of these states make it illegal, and there are no exemptions for incest or rape. So we have a number of states that completely ban abortion, and it's not just the issue of abortion, it's OBGYN access to health care. Many of us as women may have issues with hysterectomies or different things, and we need competent medical providers. And they are just not being trained in those states that are banning abortion. So right next door to us in Idaho, there's no OBGYN care available. With the threat of prosecution, the doctors are no longer providing any kind of procedures, and so women have to travel to other states. Of course, there's life-threatening pregnancy complications and will result in unnecessary deaths of pregnant women. States imposing restrictions on abortion services are some of the worst for socioeconomic status, high rates of poverty, minimal community-oriented primary care, lack of health and social care safety nets, which Kendra will be talking about. Removing the access to abortion services leaves women at a significant increase of economic insecurity. And of course, those restrictions will promote further inequalities. Affluent, well-educated middle and upper-class women will be able to travel to access both the maternity and the abortion services required, but many women will not. And this is difficulties for abortion. You're forced to travel across state lines. Professionals don't have the training that they need. So there's lots more mortality, infant mortality rates, and threats for our mothers' health care. There are maternal health care deserts, and this is just a form of assault against women and our ability to care for ourselves. There's other data and statistics. The U.S. really is falling behind in our maternal care, and we look more like poor civilizations without maternal care. So again, just in closing, the Dobbs really represents an assault on a female body, and the maternal death rates have increased and they continue to rise. Some states are just going to not report, and it leads us for lacking data, and it really risks the lives of women and indigenous women of color primarily. Thank you very much.
Good afternoon. It's really an honor to be here. I approach you today and the work of transportation as a social worker. I work in public health. I work in coalition building. I am not a transportation expert or engineer or urban planner. So as that context and intro to my talk, and I really thank the other panelists for laying some of the really important framing for that I didn't have to cover today, so I appreciate that. My organization, Generate Health, is a maternal and infant health coalition in St. Louis. We worked for about 3+ years before the pandemic on addressing transportation barriers for pregnant and parenting people, primarily for Black women in St. Louis, who are at disproportionate risk of maternal death and infant and losing their babies. And transportation is one of the most significant social determinants of health that is contributing to the persistent racial disparities that we have in St. Louis. Over the course of our work, we listened to a lot of women. They participated from the beginning all the way through our project and our work, identifying the issue, really defining the pain points and solutions that could be implemented. We formed a cross-sector action team that included consumers, women who were users of the transportation system, collected and shared a lot of data, and worked towards some short and long-term strategies. So a little bit of the context in St. Louis. We've heard already that delayed and missed healthcare appointments is a real thing, that transportation is a barrier too. And in St. Louis, at the time we did our work, St. Louis was the 19th largest city in the U.S. We are a sprawling metropolitan area where you really have to have a car just about to get around. Our public transit coverage at the time was ranked 68th in the country for access to jobs. And you can assume that that also means access to healthcare, to food, to other basic needs. St. Louis is a highly segregated community. We have what is considered North St. Louis, north of Del Mar, where the predominant population demographics are Black families. And 40% of households north St. Louis have no vehicle. And so the need and dependence on transportation, public transit, are pretty significant for those who face the most significant burden of maternal and infant health concerns. So there's kind of three key things that I'm going to kind of use as my guideposts in talking about our work. And I think it's one of the things that's been so central and fundamental for us has been involving, including, and really centering the expertise, the wisdom of Black women who experience the transportation burdens every day. They were integrated in our work from defining this as a priority for us as an organization and a community, all the way through the full spectrum of the work. And, you know, public health and healthcare folks, we've heard for many, many years that transportation is a barrier. And for the most part, it gets set aside as somebody else's issue to address. That we are not equipped, we don't know this sector, it's not our job or our role. But when we had consumers at our table talking about what is going to move the needle on maternal and infant health, and we held 17 listening sessions, 350 plus Black women of reproductive age, and transportation continues to rise to the top. Our leaders, including consumers, said you can't overlook that. We have to do something about this. And so we wouldn't have even addressed this issue if it hadn't been having community at the table from the beginning all the way through. We also, in addition to our own community engagement and listening, we aligned with other community groups that had residents addressing and looking at transportation. One in particular in North St. Louis that was auditing their bus stop amenities and inventorying the concerns and meeting with the transit agency and their elected officials to try to make some changes. We learned a whole lot through listening to community. One of the things that we learned too is that it was really important for us to have women at the table is because when we think about the disparities in maternal and infant health, we often think of women who are of lesser income, lower income, who are covered by Medicaid for their health care. And the assumption is that they then have access to non-emergency medical transportation paid for by Medicaid. And so this shouldn't be a barrier. And yet it is. And so listening to community, we learned quite a bit about why that is. Having consumer perspective present on our action team and throughout during the planning really helped challenge data and assumptions that those who worked across public health, and transportation had, the assumptions and the way they interpreted the data. It really changed and challenged those assumptions and held us and other decision makers to account. So part of the work that we did was to really define the pathway of how transportation was impacting maternal and infant health. So fairly simplified version and picture here, but poor transit being inadequate, unsafe, and unreliable was leading to missed prenatal appointments. It also leads to missed well child. It also leads to lack of access to jobs and healthy food and all sorts of things, which increases stress. It also increases hypertension, diabetes, leads to preterm birth, and these pregnancy complications are the biggest drivers of maternal and infant death in our community. We had a lot to understand and learn through the work that we did. And just kind of teasing out what is the impact of what is Medicaid transportation versus public transit? How is this impacting pregnant and postpartum women? These are really different systems, but they're interrelated in how they impact women and families. As we dug further to learn more into this, we learned that many women who are enrolled in Medicaid don't know that transportation is a benefit. It isn't something that the Medicaid program, and in Missouri, we have managed Medicaid, so privatized health insurance companies covering the Medicaid for pregnant women and children. They're not advertising transportation as a benefit, so it's not well known. Second, the default mode of transportation that's provided by Medicaid is a bus pass. So women were given the choice of, if you need transportation, we'll send you a bus pass. We live in an urban area, and the assumption is that there's bus transportation would be adequate to get women to health care. But that was, as we listened to women, you'll see more about what we learned as to why bus transit was not a great option for most pregnant women in St. Louis. And then we also came to better understand the very business model of non-emergency medical transportation and how that has an influence on quality, reliability of non-emergency medical transportation. So we did try to take kind of a two-pronged approach to working on non-emergency medical transportation system as well as public transportation. With our listening sessions, we had a lot of stories, a lot of first-hand accounts about what wasn't working, such as the quote on the bottom. I live on a bus route, but getting to the bus stop was stressful, traveling with kids in an unsafe environment. And those stories were really important, but we needed, and we were coached by people we came in contact with and met, like Sean over here. We needed to better define and describe it with data and evidence. The stories were compelling, but we needed more to be able to move to action. And our work was really driven by what can we do, what do we need to learn, and how do we need to organize in order to get to policy and systems change. So we partnered with the transit agency. We worked with graduate students to help us better define and provide evidence to what was happening. And so students went out and took pictures of bus stops in areas in our neighborhoods and zip codes with the highest infant mortality. And we were able to qualify sort of what the lived experience was with pictorial evidence, with mapping of overlaying the birth outcome indicators with where the routes were, with frequency, with bus stops, so that we could show that there were gaps and challenges. We had that other community engagement effort that had itemized bus stop amenity deficiencies and safety issues that we had as well. Students helped us map transit scenarios so we could describe in more specific detail what it took to get less than 5 miles for someone relying on transportation, the various scenarios that you could take this route, which would require half-mile walking and would be a little bit shorter in the long run, but you're 6 to 8 months pregnant. How are you, walking where there's no sidewalks, where there's, you saw the visuals of the bus stops. Or you could take a longer route, 47 minutes. Anyway, the chance you're going to miss a connection, be late for your appointment, and healthcare providers were on our action team saying yes, and when people are late, they miss their appointment, we can't see them, and they start the process all over again. Another innovative thing that some of the students did was to overlay and look at census data to see where there were denser pockets of women of reproductive age. And these were areas in North St. Louis that identified blocks of opportunity where we could really focus, because scoping this work was a real challenge for us as an organization that doesn't know a lot about transportation. There's so many things to focus on, and so geographically as well as issues. So focusing on certain blocks even where it could impact the most people was helpful. So all of this data and visualization helped us approach the decision makers for non-emergency medical transportation. Our action team was actually led by a really prominent healthcare leader, but also a president of one of the Medicaid managed care plans, who was able to bring the other 2 competitor managed care plans to the table, as well as our state Medicaid and the brokers for non-emergency medical transportation to the table to be able to work towards some systems and policy change. Because of the work we did, kind of inventorying and documenting the public transportation challenges and the listening sessions, the health plans agreed to allow ride service for any pregnant woman who, and they have the choice. That was a really important thing, is that women needed a choice, not just default, here's your bus pass, but you have a choice now. You can ask for a ride service if a bus is not going to work for you. So we strove to have this really a feedback loop, a quality improvement approach where we brought the consumer experience centrally first and foremost with other literature and data, documenting sort of what are the standards that should be in place, continued to collect data around those standards, what people were experiencing, and did a lot of education of every actor in this non-emergency medical system. And it led to some protocol changes. It led to better understanding how the system was impacting the lives of women. So we did have all 3 competitor managed care organizations partnering, and they standardized their transportation benefit. We did a lot of education with the broker, with their customer service staff, with the managed care case management staff, with community health workers on how to help their patients navigate transportation. And the data and storytelling that we did really helped fuel regional awareness about transportation and really some confidence for others to work on it, who could take a bit of what we did. We built on that other community group, and just kind of has been building on itself. It became one of the priorities in our community health improvement plan by our health departments. So previously, public health and health in St. Louis was not really at the table and making this a priority. And then the work that we did was featured in the Practical Playbook, which we co-wrote a chapter in the playbook about partnering with the transportation sector. So for the public health community to hear and see how it is that we could bridge the different perspectives and knowledge to come together to make some changes. So we co-authored with Sean here and my colleague Teresa Wilkie, and encourage you to check that out. So final takeaways: we didn't accomplish everything we set out to. This was a bigger scale and scope than we could have ever imagined, but we learned a lot of important lessons about systems change. I think one of the important things is we made the complexity of the transportation system more visible and understandable to public health and health sectors, who were able to begin to think in new ways about how they can play a role in improving social determinants of health. And really proud about how we demonstrated the value of centering consumers' experience and voice at every step, and gave some folks in the systems of transportation, non-emergency medical system, that experience of working at the same table with consumers. Because it's really powerful to bring residents together with system leaders. And I think we made, it's the beginning of some more larger change that we've continued to see the Medicaid managed care plans make additional improvements in their protocols even after our work stopped. So I think that the experience, while we wanted it to continue, for them to continue to have the consumer involvement with them, that didn't continue, but they've continued to use the lessons to make some other changes. I want to thank our funders who made it possible for us to work on transportation, the Build Health Challenge, and Missouri Foundation for Health. And that is our contact information. So thank you very much.
Thank you so much, presenters. Did y'all learn something? First of all, have you learned something? Have you hopefully unlearned something along the way? Because that's the other thing we forget. It's like one of my favorite questions whenever I do presentation or whenever I moderate. At the end of it, it'll come back on the moderator review, which is also kind of like your attendance sheet. So please, complete it. It's important to take note of what we learn, as well as in the process, what we unlearn, because that's why we have these sessions, right? We've heard topics from, built-in systemic inequity, right? Understanding that these issues are by design, right? They're not accidental, right? We can no longer say, I don't know how we got here. It's in the book, it's in the design process, it's in the people. It's in who is in the room, who is at the table, at the proverbial table or not, right? Also understanding, why does it have to be a table? That's one question I often like to ask. Why is it a table? Because for some people it's under a tree, some people it's by the river, for some people it's in a cafe, it's in a school, it's in a church, or some other religious building. So whatever that proverbial table, floor, chair, whatever community meeting is, we want to make sure that we acknowledge that in the process, because I believe somebody said, when you talk to community members, they'll often say transportation is a key issue. I work in the environmental sector, environmental justice. And when we do our community outreach, and we're like, well, what can we do? We'd like to hear from you on an environmental justice, perspective. And I kid you not, one of the first two responses in terms of what we need from you is talk to the DOT. I'm here representing an environmental agency. And their first, consistently, one of the first two, maybe three responses from the community is, hey, we have this issue with the transportation project. And we're like, thank you. And we will definitely do our best to communicate that and relay that information to our DOT partners. Because, as I said, this is an integral issue. It's an integrated problem where people are like, transportation is a key issue. And we're like, nah, that's not our problem. We talk about healthcare. Right? We've heard about mobility of care for self and for those who happen to find yourself in the community. We've heard about the importance of having an intersectional approach. So not just a gendered approach of like, this is a women's issue. This goes beyond just simply being a women's issue. It's impoverished people, because words matter, language matters, context matters, right? It's impoverished people. It is a minoritized people. It is people who suffer from the issues of classism as well as racism, right? It's about understanding the power of storytelling, right? Of what our speakers have done here today. So the power of storytelling as well as counter-storytelling. And so when we put all these things together, as well as the pink tax, it's always a pink tax, boo-hoo, right? And I'm not being that sarcastic, I'm literally, boo, freaking who, or I don't know, I hope it's translating correctly, it's real tears. I'm not crying here, but it's real tears. When I talk to people, as a person who's been in the transportation sector a decade plus, and I hear people internalize the experiences that they have from using the systems that we, as industry professionals, and somebody told me, oh yeah, I got robbed at gunpoint while riding my bike at night back to my place from point A to point B. Yet we keep saying, we want people to use, ride shares, but they're experiencing harassment and assault. We want people to use active mobility, but they really can't, depending on the time and date and place and distance. We're saying, hey, use these smart mobility, right? But there'll be no moderator in there. And to me, I'm like, again, I'll always say no thank you, right? Because I'm a woman and I fear for my life, right? If it's in the dark, if you tell me to ride in this really cool, smart transportation device, but I might be by myself or I might be with strangers, all these things kind of create a particular picture. And with that, I was just saying, there's all those things. When you put all those things together, think about what could, would, should that conversation on the planning side. Because too often we're trying to be reactive and address it on the post-construction side or post-implementation policy side. What could, should, would that idea of equitable transportation planning and decision-making look like if we were to be proactive about it? And with that, I'd like to open up the floor to kind of have a bit more of an engagement opportunity. So first and foremost, panelists, good question. What is your unpopular opinion about your topic of interest? I know one of them that has been brought up is, hey, transportation is a barrier. It is, if not the key barrier after economics, to a lot of these nexus issues, right? Because these are cofactors, right? Transportation is not the only problem, but it is a big problem. Whether you're talking about infant and maternal health, whether you're talking about indigenous people's access to opportunities, right? And community, whether you're talking about environmental issues and restorative justice practices. I hope I've given you some time to think. 2 seconds. What is what could be deemed unpopular or uncomfortable opinion in the nexus of the work that you do in the transportation sector? And again, caveat, I'm hoping that this is a free enough space. That is my intention, that when we come into this space to have these conversations, I welcome you to ease into the discomfort a little bit. I welcome some feedback. I welcome you to learn and unlearn. So, go back to you.
So she's asking what is most unpopular. I guess I will just say the land tenure. having all of your land taken and being moved out to a rural location is a very big challenge. As I mentioned, for housing, for jobs, it makes it hard for indigenous people to go to college, and you know, people can just say, well, just move to the city. Well, when my grandmother moved to the city, she was denied housing. She married a non-native, and when her brown brothers moved her in, the neighbors freaked out and called the owner, and so they canceled the sale. And so indigenous people don't have the opportunity to build wealth like many Americans do. Same with African Americans. If they didn't get their GI Bills to buy homes, you know, starting from the 40s, 50s, 60s, even indigenous men that served in the military. So the idea of land tenure, it's in trust. And so banks don't rush out to loan us money, and construction companies don't know how to deal with tribal land, and so that causes a lot of disadvantage. But being in rural areas with that kind of land tenure is a real challenge for mobility, access to healthcare, access to education, access to jobs.
From my limited experience, what I noticed in most conversations around transportation, it involves people who were choosing to use public transportation for their own, like, environmental reasons or health reasons. It very often, those who most depend upon public transit to get to their basic needs are not at the table, engaged, talking and sharing what works, what doesn't work. And I think it's hard, it's challenging, it's difficult to engage community in real meaningful ways, but we need to do better, because right now the most prominent voices are those who are choosing transportation for, and they have the privilege to choose transportation. And I think the other thing I want to say that is not probably not a popular thing, but on the non-emergency medical transportation thing, side, the profit motive is really significant and needs to be addressed, because it is the barrier getting in the way of doing what's right for the outcome of what our taxpayers are paying money for Medicaid to get healthcare outcomes for our citizens, and the profit motive is hindering that, where the cheapest vendor is contracted to provide transportation regardless of the quality. And the profit motive keeps the knowledge of what's working or what isn't working from being shared. So when you contract out to a broker, the managed care company is getting reports from their broker that 98-99% of the rides were a success and people are satisfied. That's not what communities who's using it experience. And so the data is not being shared. It's there in every grievance or every call, somebody saying, my ride didn't show up, I've been stuck here at the clinic for hours, I was treated very poorly in the car, whatever it is, that information doesn't go to the managed care or the Medicaid office, because they mark it as resolved when they say they fixed it. So data is being hidden, and we have to be able to challenge this assumptions. I just have a lot of concerns about the structure of being able to make really deep changes in non-emergency medical transportation when profit is at the core of the companies that are responsible for it.
And, I don't know if this is
Can y'all hear them well?
It's not.
It's on?
Okay. My unpopular opinion that I think underlies both responses is we need to reallocate funding, and we need to shift the priorities of what we fund. When we talk about generational wealth and building generational wealth, I mean, the GI Bill was not allowed for people of color, which is what hinders. Everyone talks about the middle class. Black, indigenous people of color did not have access after World War II with the GI Bill. And so that is structurally built in. So what we fund, when we talk about all these healthcare disparities and the healthcare system, It's because our federal government doesn't prioritize social services in the U.S. So therefore, we have all of this privatization and we have all these issues. But if we actually funded healthcare in the United States, that is an issue. When we talk about, I talked about in my presentation, care work. So many women are low income because we are still predominantly the ones who take care of children, elderly, other family members who need care. That falls on women. And so then that leads to other issues. So if you have to do that, you cannot fully participate in the workforce. Again, because we don't fund care infrastructure in the United States. As I mentioned, it was completely stripped from the Inflation Reduction Act. We were supposed to have paid family leave. We were supposed to have new child care. I live in LA as an assistant professor. I don't have children yet, but my colleagues who have children are like, after your check goes to your mortgage and child care, as a professor in LA, what do you have left? And so if that's a professor's salary, what are other people doing to afford child care? And so again, it's a prioritization of funding. I talked about free public transit. It should be free. People are like, where do we get the money? Look at where LA's budget goes. 90% goes to LAPD. There's where we can get some money. And so we need a complete restructuring of where we prioritize our funding. We have money as the United States. Where's it going? And unpopular opinion, too much is going to the DOD. It should be going to the DOT, EPA, everyone else. But we fund war. We don't fund social services. We don't fund programs. And so I guess that's too unpopular opinion.
Can we listen? I'm here about to have a praise break, by the way. If you don't know what that is, find out. This is why I love that question. And if you have a specific question to either or all the panelists, please begin to approach the mic, as we are running out of time always. But I would like to preface transitioning to that with this. I am so glad that really at the core of what all of you responded with is, no, feel free to stand, is the acknowledgement that it is this necro-capitalistic greed that we see going on in society. Necro-capitalism is very real. And whether we're talking about transportation, whether we're talking about the land, issue of land, considering what's going on across the globe right now, and resources and lands, and why people want to have indigenous lands reclaimed or protected, right? That's key when we're having conversations of where projects should go. How do we connect communities? How do we restore value? How do we make amends for historical issues of transportation projects that have built such a wedge of distrust with those who we're saying we're here to serve? So please go ahead, ask your question. Introduce yourself first.
Valerie Leffler, I'm with Phoenix Mobility Rising, and this is like going to the well for my soul, so thank you for the work that you do. One of the questions that I had, and I just had this moment when you were speaking, just each person today, the data that the US Medicaid and Medicare system has around the transportation equity of non-emergency medical. You know, we spend $5.7 at least billion on non-emergency medical transportation in the US for Medicaid and Medicare, but we do not have data in terms of how many rural versus urban households are served or not served. We don't have data on how many Black households versus white households are served, or et cetera, like we're beginning to, like, the eyes, you know, the lights flickering in transit. I wouldn't say it's on yet in many communities, but it's coming, and we're aspiring to it. But in Medicaid, I remember we had a project with Mississippi, and we tried to get data out of the state DOT for Medicaid, Medicare transportation, just how many people were using the Medicaid transportation in this rural county of poverty. They would not even share the data. And so I was just curious if you had any luck or any tips or tricks on how.
It's absolutely a challenge. Our state Medicaid office, shared that they spend $40 million on transportation. That's just straight fee-for-service Medicaid. That wasn't what the Medicaid managed care plans were paying, and we couldn't get that level of detail from them. So I don't know if you've checked with the state Medicaid offices to see if they have any information, but it is And when it comes to the Medicaid managed care companies, they're so proprietary about their data. We had mapped out with all three a methodology to better understand utilization and the outcomes of those who utilized the Medicaid transportation, and then track as utilization hopefully would go up, what the impact was. And we got an agreement about how we were going to measure it, but no data was forthcoming. So that's definitely an experience we had as well, and I don't have any good tips for you, so yeah.
Anyone else would like to add into that? Yeah. But I will say that feeds into the general conversation of data collection, because all three of you reflected that, the importance of not just data collection, right? Not just availability of data, because if you've ever been in my sessions, one of the things I talk about is the difference between availability versus accessibility of any resource, right? It's not enough to have available data. It's important to make sure it's accessible to those who can best use it to reach the desired outcome, right? So whether it's street and transit harassment data, whether it is infant and maternal mortality and morbidity data, whether it is access to healthcare, whether it's whatever transportation system, data is really fundamental to our decision making. Because when it comes to policies and practices, there was like, where's the data and what does it show? Because if you're asking me to change the policy, I need to show the research. To do the research, there needs to be data. And so it's almost like this consistent chicken versus egg situation, right? So if you're in a position to support that effort, please do so. We know there's nonprofits and a lot of research work being done in the space of data. Oh, quick plug, mainstreaming gender data, AME 20 subcommittee. We'll be having our annual planning, so if you're interested in doing work in that space, reach out. I will have a scan code here ready for y'all. And it's
just one other
welcome.
Thought to add. We did talk with the Medicaid Oversight Committee in our state, and the chair of that was in Missouri was a professor at Washington University, economic professor, and he was very open to trying to help bridge some of that. So I don't know if there's, that Medicaid Oversight Committee had heard from healthcare providers, hospitals that were concerned about transportation and asking for things to change, but they never heard from consumers. They heard from the vendors of the brokers, but they never heard from consumers. And so the Medicaid Oversight Committee might be a place to see if you can get some transparency.
Can we circle back to something around that, right? The idea of who actually gets to come to the decision-making table, right? Like, we consistently hear that entities, agencies, nonprofits, academia is like, hey, we want your input. And who actually gets to show up? It's those people who feel comfortable enough to show up. And yet the people who are most adversely impacted, time and time again, are not showing up for various reasons, including transportation access to those spaces, right? So when we're saying we actually want effective community engagement, we also need to ask ourselves, what does that look like? And we have a couple more minutes, 5 minutes now, so I guess I'll be closing down, unless if you have like one more quick question that somebody's burning to ask. Yeah, come on through.
Hi, Anna Ziegert, Disability Rights Washington, and I guess my question's around how we keep the conversation from getting sidelined into, well, robo-taxis or ride-hail or autonomous vehicles are going to solve all these problems. And I love, I think what Regan was saying around, like, it's actually frequent, reliable, free, safe public transit, but how do we steer the conversation that way, or techniques that you guys have tried?
One, by asking questions like that, bringing those conversations and concerns. It's so funny because I have a colleague here who works on autonomous vehicles, and I enjoy our conversations together. So how do you deploy technologies, all technologies, in a way where people have an option and it's not just one thing? I think is really what we're trying to get to. How do you have a truly multimodal society where, regardless of where you live, you have an option on your mobility mode? If you want to take a car, fine. I'm not going to tell everybody to sell their car. I have a car. If you want to take public transit or have to, you can. How do we just make sure every mode is available? And so getting to that multimodal reality is, I think, what we have to advocate for. And so in my conversations, I've even learned, how do I reframe? It's not, we can't have an AV, we can't have a ride-hailing service, because during COVID, what was it, the president worked with Lyft or Uber and partnered with them and said, I'll give you a ride. There is a real, that does serve a need, but that should not be the only need. Could we be giving out bus rides? Could we be giving out, should we fund transit enough so people can access the bus to get there? And sidewalks, can we have communities that have sidewalks? And so how do we really advocate for that multimodal? And I think that's the conversation that needs to happen. I mean, I work in the environmental justice space also, and in that conversation, no, if everyone has an EV, we solve everything. So I'm like, say what? Because look at indigenous land. Now we are mining indigenous land yet again. We're doing extraction again. And so it's, how do we have these conversations? Like, electrify public transit. We don't even have enough lithium for everybody to have an EV. Like, we need to talk about that. So it's, how do we have this multimodal reality? And so I think, again, raising that question and advocating for that, bringing people who use these different services to the conversation, and having conversations where everyone's in the room. So many of our conversations talk about, that point was raised earlier. We need conversations where all of these different stakeholders are in the room and not just one who's really pitching their one singular idea. And so how do we have these multi-stakeholder conversations in the community meetings, in testifying in front of Congress, in Congress? I mean, the conversations happening there are also problematic too. So at every level, local, regional, state, federal, having these conversations. And so I think it starts there, but also making sure we build coalitions around that work.